Good morning to everyone. In this video we are going to see about what is AIDS and what are the causes and how to overcome the AIDS by the nutritional modification and dietary modification. This is J.Merlin, Rani, Assistant Professor of Nutrition and Dietetics from SFR College, Sivagasi. So these are the learning objectives which is we are going to see about. So first we must know what is acute immunodeficiency syndrome. Primary infections with human immunodeficiency virus, HIV, is the underlying cause of AIDS. HIV invades the genetic core of CD4 or T helper lymphatic cells. HIV infections cause progressive depletion of CD4 cells which eventually leads to immunodeficiency, constitutional disease and neurological complication and opportunistic infection and neoplasms. Next we are going to see about what are the components which leads to or infect the healthy person to HIV persons. So first the virus is transmitted through the body fluids such as blood, semen, pre-seminal fluid, vaginal fluid and breast milk. Saliva, tears and urine do not contain enough virus. The most common way of HIV is transmitted via blood and semen. Transmission can also occur by sharing contaminated needles, blood products as well as by across the placenta from an infected mother to her baby. The virus is not transmitted by casual contact such as touching, hugging or kissing or through using the same plates or drinking glasses. All persons should use universal precautions to protect both themselves and others when working with body fluids. So prenatal HIV transmission can happen three ways: in utero, during birth, while through the birth canal or during breastfeeding. The next one is what are the manifestation in AIDS? There are 4 stages of HIV diseases have been characterized. First one is acute HIV infections. That is, it is a 4 to 7 weeks period immediately after primary infections when there is rapid viral replication. The infected person develops an acute syndrome characterized by the fever, malaise, lymphodenopathy syndrome, pharyngitis, headache, myalgia and sometimes rashes which may last for a week to a month. Then the next one is next stage is asymptomatic HIV. It is the stage where few, if any, noticeable symptoms occur. This stage could last an average of 10 years. Decrease in lean body mass without apparent total body weight change, vitamin B12 deficiency and increased susceptibility to food and waterborne pathogens. Then the third one is symptomatic HIV. In this stage, symptoms like fever, sweats, skin problems and fatigue can be seen. A decline in nutrient status or body composition may also occur. And the last one is progression to AIDS. A small proportion of persons infected with the virus develop AIDS and die within months following a primary infections. Some HIV infected individuals exhibit no signs of diseases and progression. A lowered viral load, a set of point, lesser virulence of the virus and protective genetic mutations appear to contribute to this stage. So the signs and symptoms of some these infections may include sweats, chills, reoccurring fever, chronic diarrhea, swollen lymph glands, persistent white spots and unusual lesions on your tongue or in your mouth. Persistent unexplained fatigue may they feel, weakness and weight loss, skins, rashes and palms also feel by the HIV infections progression stage. The next one is, so this image is carries the main symptoms of AIDS. First one is neurological symptoms. In this encephalitis, meningitis and in eyes, they can feel, they can carry rhinitis. In lungs they can feel pneumocystis, pneumonia and tuberculosis in multiple organs. Then also tumors may occur. Then So these are the nutritional problems and HIV infections. In this we can see about the what are the nutrients deficiency in progress of the HIV. So first one is decreased nutrient intake. In this they can they can achieve or they can feel or they can carry primary anorexia, peptic disease, opportunistic infections of upper GI tract, idiopathy, aphthous ulcers, zinc deficiency, pancreatic diseases and encephalopathy. Then the second one is gastrointestinal malabsorption. In this malabsorption, they can feel mucosal diseases, infections, inflammatory, disaccharidase deficiency, protein-lasting enteropathy, fat malabsorption, hepatopiliary. Then the third one is increased nutritional requirement, protein fasting, hypermetabolism, and the last one is psychosocial factors, poverty, illness in biological family members, limited access to health care, and micronutrient deficiency. During HIV infections, nutrient requirements are increased to sustain immune cell turnover. In particular, deficiencies of vitamin A, zinc and iron adversely affect immune functions through different mechanisms, and their corrections can restore immune functions, though they through the different mechanisms, and their corrections can restore the immune functions, though they do not compensate for lymphocyte depletion which occurs in HIV infections. Iron is the key component of cytochromes that medicate cellular energy metabolisms, as well as of important component of cytochromes that medicate cellular energy metabolisms, as well as of important enzymes potentially influencing immune cell turnover. Zinc is important in the activity of many enzymes, DNA binding proteins and the thymic hormones, thymolene, and its deficiency impairs the lymphatic functions. The active metabolite of vitamin A, retinoic acid, affects the thymic hormone production in immunological significant cytokines such as gamma, interferon, and interleukin 4, and influences the ability of cells to respond these cytokines. In addition, low levels of 1,25 dihydroxy vitamin D and vitamin E have been reported in various HIV infected populations. Deficiency in beta B vitamins can also compromise immune functions by virtue of their roles as cofactors in many enzymes, including those involved in nucleic acid synthesis. Then the last one is macronutrient deficiency. In symptomatic patients, mild weight loss may be noted. Early studies documented disappropriate depletion of body cell mass in 8 patients with clinical complications. Body cell mass depletion is associated with the variable amounts of fat depletion and with expansion of the extracellular spaces. Weight loss, wasting, or due to lack of inadequate or adequate intake, malabsorption, metabolic irregularities, uncontrolled opportunities, infections, and lack of physical activity. Next one is components of medical nutrition therapy. In this, the first one is nutritional screening. Ideally, all persons with HIV infection should be screened for nutritional problems and concerns at the time of their first contact with the healthcare professionals. Routine monitoring should be performed and action should be taken accordingly. Then the second one is nutritional referral. Nutritional information should include the following: current diagnostics and medical history, referring healthcare providers, a nutritional prescription or a desired outcome, clinical symptoms and feeding route, weight history and body composition, recent biological data, current medication including drugs, vitamins, minerals and dietary supplements, and lifestyles. Then the next one is nutritional assessment. The diet should be evaluated for nutrient adequacy, especially of nutrients involved with immune functions, height, weight, hip to waist ratio, neck circumferences and measurements of either lean body mass. Calculation should be compared to each other rather than to published references. Serum albumin, pre-albumin, retinol binding protein, transferring and total ion binding capacity can be used for monitoring changes in visceral protein status. Then the next one is neutral requirements such as protein, fat, fluid and electrolytes, vitamins and minerals. The first one is energy. Energy and protein needs vary depending on the health status of individuals at the time of HIV infections. Then second one is protein. High protein diet promotes the positive nitrogen balance, lean body mass repletion. Protein requirements may be estimated at 1.0 and 1.4 gram per kg for maintenance and 1.5 to 2 gram kg for repletion. The next one is fat. In individuals with a malabsorption of diarrhea, use of low fat diet may aid in management. Medium chain DGL oil should be given for decreasing stool fats and stool nitrogen content in the reducing the number of bowel movements and abdominal symptoms. Fish oil when given with MCT oil may improve the immune functions because this combination is less inflammation promoting than the usual omega-6 fatty acids. Then the next one is fluids and electrolytes. Fluid needs in HIV infected individuals are similar to those of normal individuals and are calculated to be 30 to 35 ml per kg. Additional amounts are required to compensate for losses from diarrhea, nausea, vomiting, night sweats and prolonged fever. Replacement of electrolyte losses such as sodium, potassium and chlorine in the presence of vomiting and diarrhea is also recommended. Then the last one is vitamins and minerals. Studies have indicated that there is increased need of beta carotene, vitamin E, ascorbic acid, vitamin B12 and vitamin C6 and folic acid. Selenium is a biological antioxidant. Supplementation of selenium with 70 mg per day would benefit the patients. Excessive zinc is deleterious. Immunonutrients and antioxidants can also be supplemented. Then the last one is food modification. In the food modification, the food which is given to the patient, it should be served at a moderated temperature as very hot and very cold foods may be irritating to them. Mild foods and drinks like apple juice is to be given. Acidic foods like oranges, grapefruit and pineapple may cause the burning feeling in the mouth. Spices like chili powder and masala powders and salt foods should be limited in the diet. Hand foods like chapatis or toast should be made soft, milk or soup. Easy to swallow foods like puddings, eggs, noodles should be given. So thank you so much for watching this video. We can see about next chapter in next video. Thank you.